I'm a paediatric anaesthetist. I work at Chelsea and Westminster Hospital in London. I'm also the specialty lead for the Imperial School of Anaesthesia. And this is very much a personal view of why I use TIVA and why I think you and your patients and your department would benefit from embracing TIVA to a greater extent. So the key messages of my talk are that more widespread use of TIVA in pediatrics will improve the quality of care for children with less airway irritability, less emergence delirium, and less postoperative nausea and vomiting. It will also allow us to deliver medicines optimization, so better outcomes, reduced waste, and improved safety for pediatric patients. But it needs changes in behaviour and departmental culture, as well as some investment in infrastructure. So this kind of describes what I do. So we at Chel West, I'm a group of one in 9, 1 in 10 consultants who share the paediatric load. We have a separate paediatric theatre complex with 4 theatres, but we don't have a PICU. So we do sort of sharp end of DGH pediatrics, if you like. We do a larger proportion of smaller children, but we can't ventilate post-op. We rely on retrieval if our patients need to be ventilated. So that does determine what sort of work we do. We are the neonatal surgical centre for North West London, so we do a lot of neonatal surgery as well. So the majority of my patients are high turnover ASA 1-2 patients. So I'm going to just talk a little bit about quality improvement, and again, this is my kind of personal view, my thoughts on why I use TIVA. So I've broken that down into: is there a need? Is there any evidence? And is there a bigger picture? So I think this is a slide that I've taken, or a diagram that I've taken from data from NAP5. So that was the NAP project that looked at awareness. But what this is doing is just describing paediatric anaesthesia practice across the UK. So approximately 500,000 paediatric cases a year, which was 13% of the total in the NAP project. About half of those are preschool and below. So about half of the workload are preschool-age children. The chart shows the distribution of case mix divided into the 3 ages: infants, preschool, and school-age children. And what I've highlighted there with the red and the blue dots are the majority of those cases are head and neck, many of which are shared airway cases, so ENT, dental, and max fax, and so on. And then there's also a large group that are effectively kind of deep sedation cases, so radiology, minor procedures, gastroenterology. So this performs a large part of our workload. So to look at the question of is there a need, I'm going to, is there an issue, rather. This is, I'm just going to mention some of the data from the Apricot study. So I'm sure most people are familiar with the Apricot study. Did Nottingham contribute to the Apricot study? Okay, so the Apricot study was the incidence of severe critical events in paediatric anaesthesia across 31 countries, 260 hospitals in Europe. So over 30,000 procedures and children took part. So this was a snapshot. So the critical events were very clearly defined, and when an event occurred, there was a detailed information collected and submitted and presented in this paper published in the Lancet in 2017. Actually, it was released on the same day as the Brexit result, which is interesting. So the mean age of the children was 6.3. The overall incidence of severe critical events was 5.2%, so that's 1 in 20. So that was a bit higher than previously reported. The majority of the critical events were respiratory events, so 3.3 of the total was respiratory critical events. But there were limited sequelae, so the sequelae were no, and the mortality was similar to previous studies. So the incidence of events was higher, but the mortality was the same. And so the primary outcome was to report the age groups and what occurred. So this is a chart that just summarizes the cardiovascular in red and the respiratory in blue according to age groups, and you can see that the majority of these events occurred in younger children. If we break down the respiratory events, which are shown on this chart, again according to age, so neonates through to adolescents in the different bars here, and the different types of events that were clearly defined: stridor, aspiration, bronchospasm, and laryngospasm. You can see how those varied according to age. So in the infant group, 6.5%, 4% in the preschool age group. There was a sub-analysis of that published this year in Anaesthesia, which described the UK data set. So the UK data, which formed the largest proportion of the cases in the apricot data set, was analysed, and the distribution was the same. So the younger children are the ones that tend to suffer the highest incidence of severe respiratory critical events. The pattern was similar, although the overall incidence was lower. So laryngospasm was the most common overall event, and I'll talk a little bit more about that later. So the secondary outcome measure that they were wanting to look at was risk factors. So for each event, the details of the history were collected, and those were analysed to indicate the relative risk of a severe critical event occurring in the presence of that risk factor. And they were broken down into categories, so airway sensitivity, physical condition, anaesthesia plan, and so on. I've just highlighted some of those which are relevant to this talk. And many of these are familiar to clinicians. This is not new, but it's quite useful to have some numbers attached to them. So there's two things I want to highlight. One, the how common some of these things are, and we recognise this from our clinical practice. So, 13.5% of children having an anaesthetic had a history of an upper respiratory tract in the last 2 weeks. Wheeze, asthma diagnosis, and on this column, the relative risk of a severe respiratory critical event occurring with that risk factor. So you can see snoring, for example, 14% of children had that reported in their history, and the presence of that symptom resulted in twice the incidence of severe respiratory critical event. So what I think this also indicates is the risk factors that may contribute to difficulty with ventilation and therefore anaesthesia delivery, which are associated with severe critical events. So if you can't and the majority, I think by far the majority of these cases were volatile delivered cases. If you have difficulty delivering your volatile, you're more likely to, and you have other risk factors, the chances of there being a respiratory critical event are greater. A couple of things down here. So ENT was the most common category of surgery in this study, and there was a higher relative risk of a severe critical respiratory event in those patients. Intravenous induction actually reduced the relative risk of a severe critical event. So they also looked at how institutions vary. They looked at caseload, and they described in this chart how the relationship, there was some evidence for a lower incidence of respiratory critical events in centres with a high caseload, as you can see here. But what they also commented on was the variation in the incidence of these events in different institutions. So up to some institutions describing up to 17% incidence of severe critical events. So this also highlights the role of education, training, and performance review in terms of improving how we can try and prevent these sorts of things from happening. There was a third sub-analysis of the apricot data, specifically looking at airway management in paediatric anaesthesia, published in the BJA last year. And I've just taken this table, which you probably can't see very well at the back, but essentially what this shows is similar to what I've said already. If how respiratory comorbidities such as asthma, wheezing, recent respiratory tract infection, snoring, and passive smoking increase the relative risk of respiratory critical event. So the more of those that you have, the much greater there is of there being a respiratory critical event. Also, the more attempts of trying to get to secure the airway, greater incidence. And then this is the type of airway management, and so face mask versus tube was a lower relative risk, and likewise with a laryngeal mask versus tracheal tube. So this is all bringing me to this concept of separation of concern. So this is I was in theatre a couple of weeks ago with one of the trainees, and he came up with this term, and this is a term from, I think it's from programming. So this is the idea that when you have one process that's dependent on another process, if the first process fails, then you can compromise the other process. So this is just a way of thinking about how a volatile anesthesia is dependent on airway and alveolar ventilation for delivery, and if that is compromised, then your ability to maintain a deep plane of anesthesia is compromised. And intravenous anesthesia obviously separates those two issues and allows a more stable plane of anesthesia to be maintained while dealing with difficulties with the airway management. And I mean, the reality of pediatric anesthesia is that airway management is tricky. We've got different sizes. We've got lots of in head and neck surgery, for example, things can change. So what this is a trend graph, and this is trying to illustrate that point. This is, I was doing a plastics list with a relatively new core trainee, and we hadn't been able to get a cannula in, so we did a gas induction and put the laryngeal mask in, and then came into the operating theatre, and noticed the saturation deteriorating, and we realised that moving the child from the trolley onto the operating table had resulted in the laryngeal mask position changing and obstructing the airway. So you can see the familiar sequence of events here, the increase in the oxygen level, the end-tidal CO2 being high because the tidal ventilation is poor, and so on and so forth. And the next case, fortunately, the airway management was better, and so that's not the case here. Now, we were managing, we'd done a gas induction, but then switched to intravenous anesthesia. So that's why the end-tidal SIVO is dropping here. But this is just trying to illustrate the point of dependency of the airway and delivery of anesthesia. So just to summarize what I've said so far, respiratory critical events are common, So the risk factors, particularly in younger children, comorbidities and difficulty securing the airway increase the risk of respiratory critical events, and separating anesthesia delivery from alveolar ventilation can result in a more stable anesthesia depth and reduce respiratory critical events. And I think that's one of the key reasons why I think TIVA makes sense in pediatrics. So the next little bit that I'm going to talk about is evidence, and what evidence is there for benefit. So this is a little case history of a child that I have come across on a number of occasions. So the history of neonatal seizures and the facial discoloration meant that the child had an MRI scan at about 6 months of age. And this is what was written in the notes. Child cranky post-anaesthetic, parents very anxious, please give midazolam next time. So quite a familiar scenario, I'm sure, describing the likelihood of emergence delirium. So this is the second anaesthetic. The child was inconsolable in recovery, having had a lasering of the face. So not a particularly painful procedure, but the child just went absolutely crazy and they couldn't do any observation because it was thrashing around so much. And the mother, of course, was completely beside herself. So when she turned up on my list for the third anaesthetic, she was in a real state. And in fact, I think I was warned about her, and I spent quite a lot of time preparing her. But in the end, what we did is because the mother was very wound up about cannulation and as well as the potential that her child was going to be very agitated post-operatively, and so this is just a scenario of emergence delirium. What I did is I used dexmedetomidine nasal pre-medication, and then the child was sedated, put a cannula in, and a very low dose propofol infusion, and the child was fine. And subsequent, the fourth, fifth, and sixth anaesthetics were all very similar, and the mother was much calmer. So there is clear evidence that intravenous induction and maintenance with propofol reduces the incidence of emergence delirium, and this is this is data from a systematic review in the Cochrane database, looking at the effects of sevoflurane versus other general anesthesia on emergence agitation. These are 14 studies, and the key message is that the relative risk of emergence delirium is reduced to a third in patients who receive a total TIVA anaesthetic. And if they have a gas induction and that then continue on with a intravenous maintenance, the relative risk is 0.6. So there's still a reduced risk, but it's not as strong. And this is a funnel plot, just comparing all the different techniques in this systematic review, with the highlighted ones being the studies looking at SIBO versus propofol, showing that the actual quality of the data is pretty good and the evidence is pretty strong. So going back to this idea of just to link the first bit of the talk about and the second bit, which is why I wanted to show this. It's not uncommon that when we deliver children in recovery, having had a dental clearance or their tonsils out, there's lots of reasons why their airways may be obstructed or their tidal ventilation may be suboptimal. So, packs in the mouth, blood. I'm sure this is very familiar to those of you that are doing these kind of cases regularly. So what I'm trying to show here is the impact of an obstructed airway on the washout of sevoflurane. So the reason I can demonstrate this is because on both of these cases they had a gas induction and then switched to an intravenous anaesthetic, and so I'm just you can see the slope of the curve is different. It's a much more rapid washout when you have a good tidal ventilation or unobstructed airway, and I think the impact of a prolonged low dose end-tidal SIVO during the washout phase could result in greater airway irritability, as well as a prolonged period of low dose SIVO, which is more likely to result in emergence delirium or agitation. So the bigger picture, this is just one study that I want to show you because I think it's quite interesting. This is published 2015 in the European Journal of Anesthesiology, and the title are Postoperative Behavioural Changes After Adenotonsillectomy in Children Influenced by the Type of Anesthesia. So this is the same anaesthetist or same anaesthetic and surgical team who randomized 6 to 12-year-olds to have either an intravenous anaesthetic or a volatile-based anaesthetic for tonsillectomy, and then they looked at post-operative negative behavioural change up to 6 months post-op, and they so the things that they were looking at were generalised anxiety, aggression towards authority, separation anxiety, and withdrawal. So these children all had IV cannulation pre-op. They all had midazolam pre-op. They all had 2 mics of fentanyl intra-op. And they were paralysed and intubated. And the children who had the sevoflurane had a gas induction and sevoflurane maintenance, and the ones that had the other group had propofol induction and propofol maintenance. And you can see that there's no difference in the first week, first 2 weeks post-op, but in the in the 2 weeks and 6 months review, there was a significant difference in the incidence of post-op negative behavioural change. So this is quite interesting, I think. I'm not sure what the reason for it is, but I think it's something that you should be aware of. So the second part of my talk is about medicines optimization. So NICE describes medicines optimization as a person-centered approach to safe and effective medicines use to ensure that people obtain the best possible outcomes from their medicines. So it's much more related to polypharmacy and medicines use in diabetes and all that sort of stuff. But I thought it's an interesting way of looking at TIVA. So the Royal Pharmaceutical Society says the goals should be to improve outcomes, to reduce waste, and then to improve safety. So once again, is there a need? Is there any evidence? And is there a bigger picture? So this, I'm sure, is very familiar to many of you that anaesthetize small children. This is a cartoon that Steve Yentis wrote or drew when he was still a paediatric anaesthetist. He actually did a fellowship in paediatric anaesthesia in Toronto, but I think this kind of experience probably made him decide he wanted to do obstetrics rather than paediatrics. So what I want to talk a little bit about is sevoflurane exposure in the workplace. Now, what's interesting is exposure to anaesthetic agents in the operating theatre in the anaesthetic room was a big issue, I think, in the halothane era, but it's not such a big issue nowadays. And in fact, there's no workplace exposure limit for sevoflurane, which I found a bit surprising. But once you start to do more, when I was a fellow at Great Ormond Street, I remember those airway lists and how you felt at the end of the day, having done a day of MLBs. And if you speak to the staff in our theatres, they notice a difference if they're doing a day of dental with an anaesthetist who's using inhalational anaesthesia versus a TIVA. They notice a difference. You can feel the difference at the end of the day. So, I mean, there's no evidence that this has an impact, but nobody's really looked into it. And the focus is really on air conditioning and gas scavenging systems. So this is, I was interested just, over the last couple of years, we've had workplace exposure monitoring on 2 occasions in our theatres. And this is what happens. This is a gas analyzer that sits in the corner of the anaesthetic room, and they've got some tubes coming in to the operating theatre or on the top of the anaesthetic machine in the anaesthetic room, collecting samples. And again, this is not rocket science, but here, so they came along and they do the sampling in all of the theatres or theatre complexes in our hospital. So main theatre, peds theatre, day surgery unit, and so on. And you can see, as paediatric anaesthetists, we're generally working in an environment that's more polluted than other environments, and the reason for that is obvious. We do a lot more gas inductions. We use we don't use cuffed endotracheal tubes and so on. So we can't really complain too much about that, but it is different. And this also impacts on the recovery. If you look at the recovery, that may reflect a higher turnover of cases. But one other thing I wanted to point out is when they did this monitoring, they noticed that actually the levels of sevoflurane in the MRI induction room were dangerous, and that's probably because, as is probably the case in many hospitals, the MRI unit, or it tends to be an add-on, or it's probably a part of the hospital that may have changed more recently than some of the theatres. It's not the infection risk is not high there, so they don't have quite the same interest in having these air conditioning systems. So in actual fact, our MRI units, if you do 4 cases in there in the morning, you're probably working in an unsafe environment. And a couple of years ago, I was at a meeting in Sweden, and I was shown the MRI unit over there, and it was quite interesting what some of the differences that they had. So first of all, there's this massive tube here that's like a massive vacuum cleaner that is used to reduce the exposure of the staff to sevoflurane. But they also actually have a culture whereby many of the children will arrive in the MRI suite with a cannula in. That's never going to happen in my hospital, but it's just interesting that's how they, one of the things that they do to improve efficiency. Those that are difficult to cannulate, they will cannulate after a gas induction, but they don't actually have a vaporizer in the MRI, in the actual scanning room. So that all of the patients are being managed on a TIVA anaesthetic in the MRI suite. So the second part of this medicine's optimization concept is there evidence? And what I'm going to talk about here is laryngospasm. So this is back to the apricot study and how the UK data set compared with the non-UK data set. So there was a significantly lower incidence overall of severe critical events in the UK data set, and this is what's been reported in this paper published in April. So the incidence in the UK was 3.3% versus 5.8% in the non-UK data set, which is good news. The main reason being lower incidence of these things, but the overall incidence of laryngospasm was the same. So laryngospasm is occurring at the similar rates across the countries that contributed. This is a little bit more detail of when the laryngospasm occurred, and I just want to focus on two aspects of this. So this is time of occurrence, induction, maintenance, and awakening. So it's pretty evenly spread across those, or it's been described as occurring and pretty evenly across those times. In the non-UK, there was more laryngospasm at the end of the anaesthetics. I mean, we probably don't think too much. We don't worry too much about laryngospasm. We think of it as just an event that happens in pediatric anaesthesia, and it's kind of part of the bread and butter of pediatric anaesthesia, and that's because it's largely uneventful. Occasionally, you have a bad case of laryngospasm, and the child requires prolonged intubation, or has pulmonary edema. Now, I've actually had a case where that happened, and it's one of those cases that still wakes me up in the middle of the night in a cold sweat. So I've been to this place, and it's not a very nice place for the patient or for the anaesthetist. But I just want to present a couple of papers here, and these may be considered controversial, but this is the respiratory reflex responses of the larynx differ between sevoflurane and propofol. Again, most clinicians would say, well, we kind of know that, but this is just interesting. So this is a controversial series of studies where children and their parents were consented. So these are 2 to 6 year olds, where they set up this model to actually provoke laryngospasm, which I know sounds, and I'll get around to that in a second. But just to talk you through that, children were anaesthetized with either sevoflurane or propofol. They had a BIS monitor on, and a laryngeal mask was inserted, and then a fibre optic scope and distilled water was sprayed onto the vocal cords while filming, and then the pictures were sent to independent observers who scored what they observed, and I've just presented part of the results there. But there was a significantly higher incidence of both episodes of laryngospasm of 5 and 10 seconds in the group that were being anaesthetized with sevoflurane. So they're not lightly anaesthetized; they're properly anaesthetized according to the BIS levels. So they said, I think most of us think of the idea of laryngospasm in children as this is a thing of, it's a function of being a child. It's a developmental thing. Now, obviously, whenever I talk about these papers, there's always a kind of a hiss in the audience about, and the same authors have published 2 other papers, and the second paper, which is actually one that wasn't of great clinical interest, but it attracted a huge amount of essentially criticism. As you can see, the publication was accompanied by 4 editorials, and there was correspondence where their methodology was criticized and considered unethical. And actually, I've spoken to one of the authors, and the main author was quite badly affected by this. But I think it's actually really important research to present. And this is their most recent publication, which, despite the criticism from the one in Anesthesia, this one is also very interesting. And they published this in Paediatric Anesthesia, which the references there, 2017. So what they did here, same model, but what they did is they looked at the incidence of laryngospasm at 2 depths of anesthesia with sevoflurane. So 2.5, so that's MAC, and double MAC essentially. And they were monitoring the BIS. So this is the BIS on here, and you can see, the tendency is that children are more deeply anaesthetized if you believe the BIS. But what's interesting, so the incidence of laryngospasm was 32% in the MAC group, but still 18% in the double MAC group. So deepening anaesthesia doesn't prevent laryngospasm if it's provoked, and I think that's a really important message. So, is there a bigger picture? Well, as was mentioned earlier, the association, college, and so on are very keen that we increase our awareness of environmental issues and how they relate to anaesthesia. And this is some of the statement, the joint environmental policy statement. So they are asking, suggesting that we think not only about the patient, but the consequences beyond the patient of what we do. So, and I've sort of summarized that in terms of outcomes that are not necessarily directly related to the patient in front of you, but to more broadly the community and the population, and in particular the carbon footprint. So there's been a lot of interest in this more recently. These are pictures of children will be taking a day off school to protest and raise awareness of this issue, which I'm sure may have affected you here as well. So I asked the question: are we as paediatric anaesthetists the worst polluters? And this is some data from the most recent NAP study. These are proportions rather than absolute numbers, but so these are the choice of anaesthetic agents for induction and maintenance in different age groups. So as you would expect, the children having anaesthetics a much greater proportion are going to have a gas induction, so 25%. But if we look at maintenance, a lot more nitrous oxide is being used in paediatric anaesthesia, and the lowest proportion of children are receiving propofol anesthesia in paediatrics. To what extent are we contributing as paediatric, or when we anaesthetize children, to pollution? Now, the reason that this is important, this is trying to look at the life cycle greenhouse gas emissions of anaesthetic drugs. So that means you look at the carbon footprint from research and development to disposal. And these are two charts, and you can't see the detail, but you can just see the proportional differences. So these charts show how propofol over here compares in terms of its greenhouse gas emission comparatively with the volatile agent. So there's a much lower production of, or much lower carbon footprint, if you like, from manufacture and in particular the disposal of propofol. So the light blue parts are the pure agent itself, and the dark blue parts are when it's the addition of nitrous oxide to those when it's used with nitrous oxide. And you can see you can't see, but I can tell you there's a factor of 4 difference in the carbon footprint. So a factor of 4 lower with propofol. So changing behaviour and developing an infrastructure is the final component of my talk, and this I've just tried to illustrate my use of TIVA and how that's changed. So this is, when I was a trainee, I had a little bit of experience of TIVA just working in certain hospitals where there were consultants who were enthusiasts. When I was at Great Ormond Street, we were using a lot of intravenous anaesthesia for hemonc, so short, painful procedures, but not really anywhere else. When I did spend a year at BC Children's Hospital in Vancouver, and they were starting to use TIVA a lot more for dental, for radiology, and so on. And I got a lot more experience of using it there as a fellow. But when I came and got my consultant job at Chel West, I didn't really use it. And I think what I've highlighted here is the kind of what the approach that most anaesthetists use, which is we only tend to use TIVA if there's a contraindication to use volatile. So there's a reason to avoid a volatile agent in children, and that's how I was using TIVA, and I think that's how the majority of paediatric anaesthetists probably approach or decide to use TIVA nowadays. Around about 2011, I was asked to do a talk on TIVA, and so I thought, well, if I have to do a talk on this, I need to start actually getting some experience of using it. And when I got more experience of using it, so I introduced it into my practice sort of slowly. I initially with the simple plastics cases, and then actually at that stage, one of my colleagues was already using TIVA for gastro routinely, and that makes a lot of sense. And so I introduced it into gastro and to plastics. And once I started to get more experience of it, I started to realize that there were some children that really benefited from having that, from having a TIVA anaesthetic. So those ones where they have additional risk factors like post-operative nausea and vomiting, emergent delirium, they may have had a history of that, recent upper respiratory tract infection, and so on. And once you get more experience of using the technique, actually now I'm at the point where it's my technique of choice. And so I probably use TIVA now in about 85% of my cases. So this is about culture. I say to parents, I have a plan A and a plan B. My plan A is to put a cannula in. If we can't get a cannula in, and obviously I take into consideration the patient's previous experience and so on and so forth. But I think a lot of perception, parental perception is they think that a needle is going to be painful, but actually forcing a mask on a child's face is also pretty unpleasant. Well, one of the barriers to behaviour change is, I think the big one is that it's a lot easier to use a vaporizer, let's face it. A vaporizer is just there, it's got the drug in it, you don't have to draw anything up, it's very easy to use. There are, if you there's a definite factor involved in choosing to use intravenous anaesthesia. You have to get the right syringes, or the kit, the right pumps, all that sort of stuff, and it's a bit of a faff. So that's probably what the main reason that anaesthetists choose not to use it. And the other main reason is not having the experience of it. So I think if you want to develop the infrastructure, you need to involve a couple of other people, a couple of other key players. The ODAs. This is our lead director pharmacist who's done a lot of work with us, and she's been amazing in making sure that we're well stocked up with the right drugs, and also the nursing staff and managers who may be responsible for making sure that you have the right equipment in the operating theatre. So when we started, we would have a couple of ampules of 20 mil ampules of propofol, but once we started to use more propofol, the pharmacist would make sure that we had the 50 mil ampules. And then when she noticed we were using a lot more, we get our propofol delivered in these 10, 50 mils at a time, and there's a cost saving in that. Also, she just managed to keep us stocked up with remifentanil, despite the recent crisis with remifentanil. We always seem to have remifentanil in the cupboard. Having the admin sets, if the ODPs know what you do and they are on board with you, they'll make sure that there's the kits there when you turn up to do your list, and you don't get the pump set up the wrong way around. So there's just a couple more slides I think are important, and these are some little bits of work that I've done together with the pharmacist. If you start to use TIVA, you save money, and this is, I think, managers like to hear this story. And this is the combination of money that our paediatric theatres spend on Remi, propofol, and Sevoflurane. And you can see when we started to use more intravenous anaesthesia, so this is not the bottom of the axis is 5, so delivering the same number of cases in those 2 years, we spent 17% less, about £12,000 less on those three drugs. And this is a similar version of that. So the blue line in the background is our monthly, how much we spend every month on 5 drugs, so including alfentanil and desflurane. So this is the average. The red line is the average, and this black line is the number of cases. So we've, when we started to use TIVA, we immediately saved a lot of money, and that cost saving has been sustained through increased availability of pumps, more people using it, and despite the cost of sevoflurane actually going down, I've just got, I think, one more important thing. So the pumps will pay for themselves. We have to have pumps, but they'll effectively pay for themselves. And this is what I wanted to just show here. So we're up to about 26% of our cases in paediatric theatres or TIVA. This is some data that one of the registrars presented at the APA meeting last week, trying to do a cost comparison when we're including admin sets, the cost of 2 pumps over a 5-year period, and the syringes. So the blue line is the cost per case using a TIVA anaesthetic versus a volatile anaesthetic. So that things change. The price of sevoflurane dropped, and that's why this line is going down. And the price of remifentanil dropped, which is why this line is going down. But at the moment, that there's no real difference in the cost per case, whether you use TIVA, taking into account £1 per case for the pump and £5.50 for the administration set. So the overall cost is very similar. This is my default technique, tonsillectomies or appendicectomies, as well as all of the other stuff. So potential benefits of TIVA in children: A, B, C, D, and E. Airway, brain being delirium, post-operative nausea and vomiting, and negative post-op behavioural change. Cost saving, drug exposure to staff, and environmental benefits. And so, to summarise, as I said, more widespread use of TIVA will improve quality of care, deliver medicines optimisation, and changes in behaviour are needed, but investment in infrastructure will deliver short and long-term benefits. Thank you very much.